Welcome everyone to HQI, Stopping Sepsis in Long-Term Care, Assessing Sepsis Risk. We want to welcome participants in the Sepsis Project in both Maryland and Virginia, as well as welcome Nursing Home Improvement Network participants who have also joined in today. Next one. Today we're going to discuss sepsis risk. We're going to present how to use the nursing assessment process to better identify a resident who's at risk. And you're going to receive a tool that you can use to evaluate your admission assessment process and make sure it's as robust as it needs to be. We'd like you to meet your sepsis support team. Deb Smith, who is an improvement consultant and she works with Virginia. Myself, Candy Hamner, I'm an improvement consultant who works with Maryland and Virginia. And Lisa Mark, improvement consultant who works with Virginia. Since we have Nursing Home Improvement Network participants today, we're going to do some review about sepsis. And the 3 slides I have coming up are actually from CDC's website, and I have it listed on the bottom of this slide, and it's from the sepsis fact sheet. It's really written for laypersons, but I think it's some important information to kind of get us focused. What is sepsis? And I think it's important to understand it's an overwhelming and life-threatening response to an infection. It is your body's response to an infection, and it can lead very quickly to tissue damage, organ failure, and death. It's important to know that anyone can get sepsis, and it can get it from any type of infection, even a minor infection. Sepsis often is associated with infections that originate in your respiratory tract, such as pneumonia in the urinary tract and kidneys, skin, and in the gut. And frequently, it's staph aureus, E. coli, and strep, a few types of strep that actually are the organisms that frequently cause sepsis. There's always a question of there are certain people more likely to get an infection. And anyone can get it, but it's more likely to occur in people who are over the age of 65 or in children under 1, and people who have weakened immune systems, chronic illnesses. And when you think about our nursing home residents, most of them, just being in a nursing home gives them 1 stripe. Many of them have comorbidities, most of them I think do, and they're usually over the age of 65, so they're starting out at risk. And one of the most difficult things is there's no such thing as a single symptom of sepsis. It's actually a combination of symptoms that result. And this next slide is a really great one for laypersons that really gives people an idea what you can expect. The shivering from fever or cold, people have extreme pain. They often feel it all over their whole body. They can be clammy or sweaty, confusion, disorientation, frequently short of breath, and have a high heart rate. For us in the field, I think what we need to think about is talking to your staff about 100. Just think about the term 100. A pulse rate over 100, a systolic BT under 100, or a test over 100. Many times in nursing homes, residents don't have a fever, but more often they do. And that can help you clue into there can be something we need to evaluate. Sepsis is a medical emergency, and this is something that I think is difficult in long-term care environment. We're used to more watchful waiting. We're used to thinking about monitoring a resident, seeing what happens, drawing labs tomorrow, and actually we can't do that with sepsis. Mortality for residents who are in sepsis, have severe sepsis and septic shock, often runs 50 to 80%. The window for treating sepsis is so tight, it's so tiny, that we really have to think more about preventing it, because that is really where we can do the most in long-term care. Next slide. This slide, I really like this one because it shows you, illustrates how critical antibiotic timing is. And this is shows that for every hour of delay in treating a resident who's in septic shock, their mortality increases 7%. CDC says Next slide. Act fast. Time matters. And this is really important. Time is tissue. Early recognition of the potential for sepsis is critical. We know that you have to have an infection in order to develop sepsis. We need to begin to think about who has one, but also who is someone who is more likely to develop an infection. By being able to do that, we have a better opportunity to treat that person before they become septic and save lives. Early recognition, early intervention. That's how we improve survival. Sepsis prevention. Prevent infections, prevent sepsis. And some of the basics are the things we need to go back over. Solid hand washing practices in your facilities. Not just a policy on hand washing, but a way to know people are following the practices in your policy, that you have hand gel available, people are using appropriate personal protective equipment, and really focus on cleaning and disinfecting surfaces. Did you know that a C. diff spore, the spore itself, not the infection, can actually live up to a year on a surface? And most importantly, vaccinate. We're supposed to anyway, but make sure your residents are vaccinated. That's one of the ways, again, to prevent sepsis. All residents are at risk, some level of risk. We know that. So who is at the greatest risk? Start off, you need to know your residents. You need an admission assessment that helps you identify who's at high risk. You need to document residents, not just their cognitive state, but their capabilities. Develop some criteria for identifying who's at risk. Know your residents' wishes for treatment and make sure they're documented so people know whether they want to be treated on site or they want to go to the hospital. Utilize a high-risk rounding tool to monitor changes in those people who you think are at risk. And utilize a screening tool for when residents trigger your concerns. Lisa's going to take you through the assessment process. At the end, we will review a tool that you can use to evaluate your admission assessment process. So I'm going to turn this over to Lisa now and let her walk you through the assessment process.
Thanks so much, Candy. Let's start off by taking a little clinical test via a multiple choice question. Mrs. Lott, 86 years old, with dementia, has become physically aggressive in the past 2 days. This is most likely due to worsening of dementia, onset of delirium, depression, or anxiety. So we'd ask if you could please open the poll. And you guys can answer that question in chat. Be sure to hit submit so that your answer takes. We'll check back with the answer in a few minutes. And there'll be a few more of these questions coming up, so please be on the lookout for those. Next slide. We would like to, for identification of the at-risk resident, we'd like to accomplish this in the next part of the webinar. We want to give you some quick ideas on evaluating your nursing assessment process and providing resources. As we heard earlier, there is an increased susceptibility within the resident population that we serve, and a combination of symptoms and comorbidities really makes it difficult to detect. That clearly marks the need for early identification, as Candy said. That brings us to the value of the nursing assessment process. Next slide. And here is the ever so familiar nursing process. If you present this to your practicing nurses, they'll probably say to you, oh, I already know this, learned it 20 years ago in Nursing 101. But we know with any core concept, there's always a need to review. And knowing the components of the process is one thing, but how well it's applied may be another. As you can see, the very first principle is assessment, and we do that via the collection and analysis of data. It's the absolute foundation and most important part of the care, because if you don't have an accurate assessment, you'll never arrive at an accurate diagnosis, and you certainly won't arrive at an accurate treatment. So remember this little thing, assessment before care. It's not the other way around, which we know as clinicians sometimes happens. Next slide. The assessment techniques and the components of the assessment process are observation and inspection, interviewing, physical exam, and data collection. Let's circle back, though, real quick to our clinical checks. Next slide. If you checked onset of delirium for your answer, then you have that correct. Next slide. So let's start off at assessing the facility processes. With increasingly complex care, it's vital that we match clinical skills to match the needs of the resident care. Do you know the abilities of your current staff to complete an accurate assessment? Does your ED program contain a component that evaluates staff skills on hire and then at least annually? What kind of skills are you evaluating? Do the skills checks match the needs of your residents and common admitting diagnoses? Everyone has strengths and weaknesses. Are you identifying the weaknesses and allowing for growth opportunities among your staff? Identify your staff mentors and give them formal opportunities to share their knowledge and skills. You have some new graduates there, and you have some nurses that have been there a long time, and they all bring different skill sets to the table. Identify the staff that are strong in different parts of the assessment process, especially with the physical assessments of auscultation, palpation, and percussion. One of the biggest hurdles is working around their scheduling, both yours and theirs. Oftentimes, staff, they're tired, they're disengaged, and they're not absorbing your information. So all of your diligence may not be paying off in their comprehension. A lot of staff struggle with test anxiety, so make sure that you're testing them in different ways and not just on paper. Next slide, please. To give you a good jumping off point for those physical assessments, we'd like to introduce you to a valuable resource. It'll help you to evaluate your own assessments and then moving forward toward enhanced education, and you won't have to reinvent the wheel. You'll see the link there, and this was actually produced as part of a grant funded by the Maryland Office of Healthcare Quality, and it's titled appropriately, Improving Nursing Staff Knowledge and Skills to Identify Changes in Resident Status. Developed by long-term care specialists, it was tested on Maryland nursing homes. You'll find in this link detailed recorded slide presentations, handouts, tests, answers. There's also a section just for GNA assessment. It takes each body system and applies the assessment processes of observation, inspection, auscultation, etc., and it actually incorporates long-term care regulatory compliance. And these multiple choice questions that I'm using here today, I actually took them from some of those post-tests, so it gives you an idea of what's in there. And again, the link is there. We encourage you to look at that. And next slide, please. So let's look at some tips for data collection. Is your process streamlined? Is everyone performing the same process? Let's look at your discharge summary. A lot of areas here for breakdown during the admission assessment. What about the handoff and transfer between the discharging nurse and the admitting nurse? Is it rushed? Is the data the hospital giving you, does it translate to the information that your staff actually needs to properly assess the resident? So when the resident shows up, you aren't taken off guard by their actual status versus what you thought you were getting. You probably have a good idea of the types and quantity of paperwork that are sent by your transferring hospital. But does that paperwork actually make it to your staff in a timely manner? Is your nurse drowning in discharge documents, taking valuable time to sort it all out? Some of you are accessing data through electronic means and paper, and some of you are actually even printing it out after you access it electronically. What about the medication portion of the discharge summary? It's one of the most important aspects of the summary. It tells you a lot about the resident care in the hospital. Are there associating diagnoses? And a lot of times we'll see that with medication orders, we're missing associating diagnoses and incomplete antibiotic orders. You won't know the length of days left to finish because it's just simply not on the discharge summary. You know, in one study that was done, the referring hospital used a nursing home admitting document as a guide when they reported off. And by the end of the study, the only part that wasn't done was the medication reconciliation process because the nurses just felt that it took too much time. Make sure that you're using family engagement during the interview to validate the resident's usual functioning. And as well, don't forget to pull in the data from all the other initiatives and all your other work on your infection prevention, antibiotic stewardship, and antipsychotic reduction. Next slide, please. So interviewing a resident. This is another part, an important part of the assessment process. Staff can't always control what's going on around them because they're constantly multitasking. But when it comes to assessing the resident, time spent here methodically will yield great results in care. And I know these points may seem common sense, but interview skills are a struggle for some, and it's not something that people know intuitively. So a lot of times they have to be taught or reviewed with. Explain the length of the time prior to the beginning for the resident. That way, if they don't feel like they're up to completing that length of time, then they can circle back with it. Always use the resident's best time of day. Use open-ended questions and summarize what the person's told you. Always maintain eye contact, especially with elderly. Avoid interruptions, speak slow, and don't make assumptions. Next slide, please. Okay, time for another clinical check. Which of the following statements reflects an objective assessment? A, appetite is adequate. B, ate poorly at lunch. C, refused all food and fluid at breakfast. D, resident is a picky eater. Okay, right back to open the poll, please. And participants, don't forget to hit submit. Okay, next slide, please. So here we are, another Nursing 101 concept, but one that often needs reviewing. Two types of data. And if you look at your current clinical documentation, oftentimes you'll see subjective data when what you really wanted was objective data. And what physicians really want during a call to report changes in resident condition is objective data. Objective data is verifiable. In the future, telemedicine down the road will help us with that, but until now it's often via the phone where the staff paint the picture by words and data to the physician. Let's take a look at a video that explains that. And this video is a great idea for ideas for you to use for staff education, especially with your GNAs.
We're talking about how we assess our patients. Okay, so we need to understand the difference between objective data and subjective data. First of all, when we talk about objective data, we're talking about things that we can see. Okay, we're talking about our five senses. Can we hear it? Can we see it? Can we taste it? Hopefully we're not tasting it. We're talking about nursing care. These are things we can see with our five senses. So with these types of things, we're talking about our vital signs, respiration, blood pressure, heart rate. We might be talking about wound appearance. We might be talking about how the patient is ambulating. Things that we can actually physically see on a monitor, on our patient, that's objective data, things that we can observe. Now, where we can get a bit confused when we talk about subjective data. Subjective data, we gather it from what the patient tells us. Does the subject tell us something? If the subject, being the patient, tells us something, then that's subjective data. We can't gather it from our own personal biases. So what a lot of nurses and nursing students do is they get in trouble in thinking that pain is objective, where pain is actually a subjective data point. Now the patient is telling us what their pain is, so the subject is telling us their pain is not one of our five senses. That makes it subjective data. So when you're making out a nursing assessment, when you're answering a question, ask yourself, is this something that I can sense with one of my five senses? If I can't, it's subjective data. This is something the patient tells us. Is this a feeling? Is this pain? This is what the patient is telling me about themselves. That would make it subjective data. Can we verify the information with a monitor, with our eyes, with our ears? Then it's objective. So objective data, we can see it, we can feel it, we can taste it, five senses. That was 10. Subjective data, that's something that the patient tells us about themselves. The subject is telling us. Objective, five senses. Subjective, subject is telling us. That's what you need to know from it. It's really that simple. Get out there and crush your next exam, crush your next clinical, because now you can tell the difference.
And to add an additional resource for you, HQI recently hosted a webinar on Team Steps, which focused on reducing errors through effective communication. That's accessible on our resource center through HQI, and Candy in a little bit will let you know how you can access that. So So next slide, please, and we'll check our clinical answer. So if you answered C, refused all fluid and food at breakfast, you answered correctly, and it looks like you guys are pretty good on your identifying objective data because you got that right. Alrighty, next slide, please. This is a little assessment tool developed by one of our faculty experts, Dr. Susan Levy. That's just a way for you to quickly look at identifying sepsis prevention and to use the staff education. Next slide, please. One of the most important areas to assess is cognitive functioning because the baseline here is just so essential with sepsis. The assessment toolkit has a tremendous section devoted to that, so I highly encourage that you access that. Why is including delirium so important? It's often an indicator of the underlying illness such as sepsis, difficult to detect, often mistaken as dementia, and can certainly coexist with dementia. It's very quick onset within a few hours, and your post-hospital discharges are at an increased risk. Check your discharge summary to see if there was delirium present in the hospital. Check the medication list. Sometimes low-dose antipsychotics given during a stay are a clue that acute delirium was present in the hospital, even if it was missed on the discharge document. Important to include the family members for their insight into usual functioning to establish that baseline. In long-term care, you're using the BIMS, and as Dr. Levy's pointed out on past webinars, that's a crude cognitive assessment tool. An example of a delirium screening tool is called a CAM, stands for Confusion Assessment Method, and you can access a lot of resources online for it. It's a standardized, evidence-based tool that enables clinicians to identify and recognize delirium. It can be administered in less than 5 minutes and taught very easily to staff. It's subjective, but it's a very highly regarded tool. And if you just check with your behavioral consultant and your physician, there will be excellent resources on that test. Next question, please, or next slide. So this slide shows some risk factors that can trigger delirium and is an example of content for you to include in your screening tool. If the resident triggers upon admission for any of these, then a daily assessment should be implemented. Next slide, please. Time for another clinical check. Which is the best time of the day to perform a mental status assessment? Early in the morning, after finishing ADL routines, after a nap, or when resident functions best? WebEx, could you open the poll? And participants, don't forget to hit submit so that you record your answer. Here's a list of the most common sources of infection that can lead to sepsis: UTI, pneumonia, skin and soft tissue, and gastrointestinal. Next slide, please. The following slides identify some of the risk areas and assessment essentials for the body systems. The toolkit has detailed videos for assessment in each one of these areas. Excellent resource for how to perform a physical assessment here. These are the types of criteria that you would add to one of your admission screening tools. So let's look at the integumentary assessment. The risk factors are wounds such as pressure, vascular, surgical, diabetic, burns. So your staff would want to assess for any break in the skin, abscesses, cellulitis, ecchymosis, chart, enlarged lymph nodes, drains, and IV lines. Okay, next slide. For the genitourinary system, looking at chronic or recent renal failure, history of stones, recent UTI, Foley catheters, history of BPH, urinary retention, dialysis. So you want to assess for dysuria, frequency, hematuria, lower abdominal pain, vaginal discharge. Next slide, please. Gastrointestinal risk, definitely C. diff. Candy talked about that earlier. Recent surgery, GI procedure, chronic inflammatory bowel disease. Your staff will want to assess for abdominal pain, decreased bowel sounds, diarrhea, distension, rigidity, vomiting. Next slide, please. And then finally, respiratory. Current or recent upper respiratory infection, definitely a risk. History of pneumonia during the recent hospital stay. Recent flu episode, trach. COPD asthma, assess for dysphagia, enlarged lymph nodes, sore throat, lung sounds, tachypnea, hyperventilation, and as well they'll definitely want to look back at their list of vaccines. And then you can also add to this list, recent ICU stay, post-op complications, chemotherapy, and uncontrolled diabetes. We've had past webinars on identifying the risks, so please access them through the HQI Resource Center. Dr. Levy had an excellent webinar on that. Next slide, please. Monitoring. One of the most important parts and of the end result of a proper assessment and for resident triggers often falls off the documentation radar. And we know that because it's very popular for the surveyors to clue in on the monitoring and then find missteps there. Residency triggers for any one of these areas should be assessed daily during rounds or huddles and then taper off in frequency as needed. Some of you already have a rounding tool in place, such as our Genesis colleagues who kindly shared that on a past webinar. If you have a rounding tool in place, we'd love to hear from you, and if you could share that with your peers. If you have one and it's being successful for you, please comment in chat. We'd love to see that. Next slide, please. Another fast resource for you to use, the Sepsis 100 tool, developed by the Minnesota Hospital Association. If you're familiar with our webinars, you know that we always present them, and there's a reason for that. Facilities that use them consistently find much success with them. This particular algorithm helps to establish a methodical and systematic progression of interventions, from identification to notifying the provider and steps of transfers or kept at the facility. It's available as part of the Sepsis Toolkit on the HQI Resource Center. Next slide, please. All right, time to check our answer for the clinical check. If you answered for the best time of day to perform a mental status assessment, if you answered when the resident functions best, then you got it right. And looks like you guys are good on that one too. That's fantastic. All right, next slide, please. All right, we'll go right into another clinical check. Which medications impact urinary continence? A, diuretics, B, antidepressants, C, opioids, D, all of the above, or E, none of the above. Rebex, if you could please open the poll. And good participants, don't forget to hit submit so your answer takes. Next slide, please. Here's another highly regarded tool, Interact Tools. Interventions to reduce acute care transfers. It's available as an online resource with the goals of identification, evaluation, and communication. Next slide, please. Very popular Interact tool with Stop and Watch. It's very, very effective when used in conjunction with rounding, especially for your GNA to include them in the assessment process. Next slide, please. The SBAR stands for Situation, Background, Assessment, and Recommendation. Goes hand in hand with the team steps approach to organized communication, and the link for all the Interact tools are at the bottom. Next slide, please. Here's a customized SBAR shared by our colleagues at Shady Grove. Note how methodical and uncomplicated this format is. Keeps everyone on the same page. Starts at the top of the form with sepsis criteria, and then circles down to communication that you'll want to give the physician using objective data. Next slide, please. Well, as we know, the GNA is a very, very valuable part of the assessment process. And the goal of the GNA is to teach them what to look for and why. Next slide. One of a very, very valuable resource for the GNAs, and again from the Sepsis 100 resources, is a pocket card. And a lot of hospitals and nursing homes use them, and what they'll do is they'll laminate these and they'll actually attach them to the lanyards. Next slide, please. Observations to note and report. This is an example of a form that's in the assessment toolkit, and excellent for you to teach your GNAs what to look for. Next slide, please. Here's another something for you to incorporate for your GNA assessment training for your nurses as well, and to incorporate into your screen. Findings to immediately report to the medical provider. Next slide, please. So if you answered that diuretics, antidepressants, and opioids impact urinary continence, you got that correct. And you guys are pretty good. You must have a good communication with your consultant pharmacist. You got that all correct. Next slide, please. As you are evaluating and updating your assessments, be sure to include CLOCKY. It's a very effective means for tracking education efforts related to your clinical outcomes, such as early identification of sepsis and reduced admissions. Next slide, please. So to wrap up this portion of the webinar, we'd like to give you some tips for success and sustainability. Be creative in your education. Are you a one-man show, or are you trying to do this all yourself? Identify mentors and strong clinicians among your team. Partner with your referring hospitals for assessment education. Engage your staff by using different means of education. Impromptu videos such as the one we just showed here to you today. Load it to your home screen so every time the staff log in, they can see that video. Multiple choice questions posted around the facility with a drop box for the answers. Educate with more frequency, but briefly. Access HQI's recent webinar on team steps and all of the previous sepsis videos on our resource center. Keep sepsis and assessment tools handy in front of the staff at all times. Review your assessment documentation and tools and include your consultant pharmacist, your social worker, therapy, prescribers. Ask them for their insight into, especially on those discharge summaries. Are they getting the data that they need to perform their assessments accurately? Is the data accessible? Are they having troubles, going through and electronically? I hear a lot of that from especially from consultant pharmacists. They have a hard time accessing the discharge data to perform their own assessments. What changes would they like to see? Get their insight and please use it. Finally, engage family members to obtain resident baselines and to help screen for sepsis. Host educational nights. HQI has an excellent resource called the Resident and Family Guide to Understanding Sepsis. It's a great brochure and PowerPoint that you can use. So I'll turn it over to Candy where she can discuss the evaluation tools.
Okay, so when was the last time you actually reviewed and evaluated your nursing admission assessment process? And when was the last time you looked at the policy as well as how is it implemented? How well do people practice it? It may be time to assess the assessment. So what we've got here for you is a tool that will help you actually evaluate your process to see whether or not you are including all of the things that are known to put a resident at risk. The way this is set up is the tool has on the right side, you have columns where you can not only evaluate to see if an element is present, but is it one that should trigger something in the care plan? And is it something that should trigger a follow-up? So when you're evaluating your process, you're not only evaluating to say, okay, we identify a new admission that has a history of sepsis, but should that trigger something on the care plan? And should that trigger something in follow-up? And does your process include that? As we know, any history of sepsis, whether it's current from the recent hospitalization or somewhere in the past, increases the likelihood that someone can have sepsis again. As we talked about this, the main areas to be concerned that you most frequently see sepsis occurring, not that these are the only systems, but renal, respiratory, GI, next one, and skin and tissue are all areas where you want to be assessing and making sure you're picking up all of these elements. Medication use, there are certain medicines that can impact the likelihood of sepsis, and these are listed here. It's also important to think about infection. If a resident, a new admission, had an infection while in their hospital before they came to you, or an infection is what occasioned their admission to the acute hospital, that again can be something that can increase their risk. And certainly, when you think about chronic illnesses, diabetes, especially an uncontrolled diabetic, high likelihood of sepsis. And think about that. Skin problems they can have, wounds don't heal very well, so you're really dealing with a population that can be an issue. And also, anybody with an immune disorder, people that are HIV positive and have low counts, those kinds of things are all really important because those people, if they get an infection, are more likely to develop sepsis. Next slide. And one of the things, again, going back to what we spoke about in the very beginning, time is tissue, act fast. If you're doing an admission assessment and you have signs and symptoms of infection right then and there happening, somebody with an elevated temp, somebody with a reddened area, things that are giving you the impression this person has a current infection, that needs to be an immediate follow-up. Now this tool, while it's set up right now as an evaluation tool for your entire process, can be easily adapted to be an assessment tool if you wanted to use that to actually on individual residents. You just need to change the columns to the right, and the actual assessment tool, which is available online, and if you should have received a confirmation today for this webinar, there's a link on that confirmation which will take you to this tool. It is both a PDF as well as a Word document. And you can change these columns on the right and actually do that for an individual assessment. And those instructions are included in this. Now we want to go on, next slide, and talk to you just a little bit about the Resource Center and a little bit about Nursing Home Improvement Network. The HDMI Resource Center is relatively new, and it is much easier to access than any of you may have accessed our previous network. This one is easy to access. You can get tools, resources, there's webinars there, there's articles there are a lot of things. It's being uploaded now. There'll be more on it as time goes by, and this tool will be uploaded to that as well. So it's really an excellent resource for you to access. The Nursing Home Improvement Network. I think most of you probably belong, but if for any reason you don't belong, it's really something you should consider. This network not only helps you with sepsis, like this webinar is about, but they actually focus in on helping you decrease the unnecessary use of antipsychotics, can help you with preventing and reducing healthcare-associated infections. There's help with staff stability. They work with mobility on long-stay residents, help with your quality measures, and really can help decrease potentially avoidable hospitalizations. Your links right here to get more information from them, but it's an excellent resource if you're not part of the Nursing Home Improvement Network. Please consider it. This is the contact information. Lisa and I, if you have any questions from today, you want to discuss anything from today, please feel free to email either one of us and we will get back to you. I think at this stage we would open it up to questions and answers. Was there anything in chat, Sheila, that was worth mentioning?
No questions in chat at this time, but if anyone has any questions they'd like to put in chat, you can welcome to do that on your right-hand side of the screen. You'll see a little arrow that says chat. Click that, and that'll open up your chat box where we have loaded some links from today that we've used. And I do see we just got a question from Brian in the chat. Are these slides from the presentation going to be made available? Yes. They should have went out in your confirmation email, but then we'll also send out a follow-up email with the handouts as well too. As well as this webinar will be posted to the Resource Center as well too for other team members to listen to if you'd like.
Yes. If you haven't checked your email, the confirmation went out this morning, so you should have links to both handout as well as the tool. But again, we will send out another email after this webinar.
And James, is our operator, do we have anyone on the line that would maybe like to ask a live question?
We have no one now, but if you would like to ask a question, press star 1 on your phone. Again, if you have a question, press star 1. We do have a question from Sonia.
Hi, my name is Sonia McLean. I'm in Annandale, Virginia, and I was just, because I'm new to this facility and also HQI, I wanted to know if there's a representative in this area that could possibly come in and assist us with some training.
Sonia, hi, this is Sheila with HQI. Yes, the answer is yes. And what we'll do is we'll reach back out to you, Sonia. We've got your contact information from your registration, and we'll identify what type of assistance, if you're looking specifically for sepsis or something more global as it relates to the Nursing Home Improvement Network. But either way, we are here, and we'll be glad to do that.
Thank you so much.
Once more, if you have a question, press star 1 on your phone.
Okay, James, we're going to go ahead and wrap up and give people back a few minutes of their day, and everybody always appreciates a couple of minutes extra each day. Wait a minute, do you have a question?
I'm sorry, I think we did just get a question. We did get a question. I don't want to leave this. I was asked, is it still important to consider the respiration rate when assessing for sepsis?
Absolutely. Respiration rate is very important. Unfortunately, one of the problems in acute hospitals and nursing homes is we all like to rate 20, or sometimes we get into 18 or 16. If you truly evaluate the respirations of a resident correctly, when they are up in that 20-22 range, it is a big concern as far as sepsis goes. So yes, it is important to evaluate it. One of the problems in using it is people don't often evaluate it correctly. Does that answer your question? Okay. All right. Any other questions before we wrap up? All right, well, we really thank all of you for attending today. We hope you found this to be of value. We should have an evaluation posted, and you can please complete that and help us to make the next webinar better for you. And any questions you have our contact information. Please feel free to email us, and we will be happy to get back to you. Please have a great day. And we'll see you again soon.